I think this is a situation where, regardless which one you want to go to second, whether it's Nivo or Cabo, patients now are doing well. They can go to the third line. Whereas in
Definitely
the past,
seeing that.
only 30, even at MD Anderson, only a third of the patient made it to a third line therapy, and 60% made it second line therapy. Now with all these drugs, all these therapies, we are seeing patients go to first line, second line, third line, fourth line, etc. So I think I have scenarios where patients can get Nivo for second line, and then after they progress, they go to Cabo, and then the opposite sequence, Cabo and then Nivo, and both patients are going to respond to both agents. So that's the nice thing about these two agents, is that we've seen patients respond in the third line after whether they received Cabo or Nivo in the second line. I can't say that about lenvatinib because it's a second line therapy. We don't know how len-everolimus combination is going to perform as third line or fourth line because we don't have data on that.
So Nizar, tell me a little bit about your personal experience with cabozantinib and patients that you've used it. You talked a little bit before about how many patients required a dose reduction, that the median dose given was 44 milligrams in the pivotal trial. Tell us about your own personal experience.
I think it's a drug that has value. If you look at the cost as well, you think that it is, in the field where, $10,000 is, or $15,000. This is a drug that, as I said earlier, produces a good regression, so good progression-free survival. As David mentioned earlier, 7.4 months median PFS, and that was held back with longer follow-up. So I think that translates to something the patient can wrap their arms around and see that their tumor is shrinking, and they have improvement of symptoms. Especially, I found it to be effective and a drug that I like to go to in patients with the bone metastasis phenotype. And actually, if you go back at the history, that drug was thought to be the best in prostate cancer. We know that the data there was negative. But for patients with bone metastasis, this is a drug that, unlike, for example, the predecessors of VEGF, first generation VEGF-R TKIs, pazopanib, sunitinib, this drug actually a distinction from the other mechanism of action in that patients with bone metastasis do really actually respond. And we've seen patients in my own practice. I enrolled many patients on the Meteor trial, but even off protocol treated those patients with the agent, and some of them are already on it as third, fourth, fifth line, a year and a half, and they're still doing well. So you need to know how to manage and be proactive, managing the adverse events. And I think, the drug does have activity even at a 40 milligram dose if you really need to go down there. So I think overall it's good to hear that the secondary endpoint was met and it was powered to be looked at in that way, and it did show survival. We'll hear about it in 2 days, but it's an impressive that this drug provided OS as well as PFS and a response rate after TKI in the 17 high teens. So in that regard, I see it as a clear advanced progress over axitinib, where it did not give you the OS, and post-sunitinib, the response rate was 11%, and the median PFS 4.8 months after sunitinib. This one is 7.4 months. So I think it is, in my practice of protocol, I certainly will place it higher in the ranking, in the order where I will use it over axitinib, certainly over everolimus alone.
Yeah, our own experience is very similar. In fact, I think that in the kidney cancer world, we're very used to VEGF-R toxicities. Mm-hmm. I think that in the prostate world, they were maybe not as used to that as we have been over the last decade. And we've certainly not seen, with appropriate dose modification, stopping and starting, management of toxicities, anything that would have been unexpected and out of proportion to other VEGF-R related inhibitors.